Welcome to Management of Metastatic GIST, What to Expect when a Tumor Has Spread. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the VP of Program Services at the LifeRaft Group, and I would like to introduce our presenter today. Dr. Amy Crago joined the Memorial Sloan Kettering faculty in 2010 as a member of the Gastric and Mixed Tumor Service and the Sarcoma Disease Management Team, and now serves as Associate Attending Surgeon. She is an active participant in the care of patients with soft tissue sarcoma, GIST, and desmoid type fibromatosis, and coordinates a translational science research program that focuses on understanding the molecular drivers of sarcomas and how genomic aberrations in these tumors can inform patient care. We are so excited to have her speak today. She is a rising star. Amy, I turn it over to you to present.
Great. Well, thank you very much for having me today. I think that this is a very important topic. I'm going to first give some background information and then go into some of the clinical data we have that guides our management of patients with metastatic GIST, and including in that some of the ways that we use surgery to optimize patient care. So we know that gastrointestinal stromal tumors, GISTs, in the early soft tissue sarcoma literature were often lumped in with leiomyosarcomas, or what had been termed gastrointestinal sarcoma. Over the last 30 to 40 years, they've been recharacterized as a separate type of tumor based on both characteristics of the cell that they develop from, as well as the genomics of the cells themselves, the genetic changes that induce the cancer to form. So in most cases, the tumors are derived from the interstitial cells of Cajal, which are the pacemaker cells of the gastrointestinal tract. So they're the cells that tell the intestines when to move and to contract so that they can move peristalse and cause the food to move forward in the GI tract. These interstitial cells of Cajal are characterized by expression of CD117, or what in the GIST community we more commonly refer to as KIT. The GIST tumors can commonly metastasize to the liver or come back as sarcomatosis in the peritoneum, which is also functionally metastatic disease. The problem with metastatic disease traditionally was that it was very resistant to standard systemic therapies used in soft tissue sarcomas, such as adriamycin, which is what we commonly use as first-line therapy for metastases and other types of sarcoma. That said, surgery alone was also shown to be of limited benefit. So these are this is a study from Memorial looking at patients who were treated for recurrent, at that time, what was termed gastrointestinal sarcomas between 1982 and 1994. So this is before we had any type of good systemic therapy for GIST. 45% of the patients had local recurrences or sarcomatosis, so disease that had recurred within the abdomen. 55% had liver metastases, 30% had tumors that had started in the stomach, 60% in the small bowel. We know that only 33% of the patients who had tumors that came back could undergo complete resection. And of those patients who underwent resection, overall survival was very short, only 15 months. So surgery alone, even when the tumor could be removed, was not particularly effective. This is a Kaplan-Meier curve, which shows the outcomes in these patients who had recurrences. And the Kaplan-Meier curves, what they show is the proportion of patients who are still alive over time. So, for example, this is 80% of patients, and this is over time. So at 20 months after the diagnosis of the recurrence, patients who had the disease come back quickly after their initial surgery only had a 20% overall survival rate. And you can see that about half of patients had died between 20 months and 45 months after their surgeries, after their initial surgery, so not even after their recurrence. So surgery alone for recurrent disease and metastatic disease was actually quite limited as far as its efficacy. So in the late 90s, this was about the time where we were able to more easily identify mutations that were driving cancers. Hirota et al. Identified a mutation that was common in GIST tumors in the c-KIT gene. So, and this was important, KIT is only expressed on a certain number of cells in the body, so the interstitial cells of Cajal, melanocytes, and hematopoietic cells, which explained why this mutation was specific for GIST in that these interstitial cells of Cajal are one of the few places where it's commonly expressed. Subsequently, after Hirota's study, we know now that c-KIT mutations are common in GIST and occur in about 80%, somewhere between 70 to 80% of tumors, depending on the studies that you look at. These are some new diagrams just published in a review by Drs. Blay and Von Maren in Nature Reviews, which is actually quite an excellent review, and I recommend to everybody to read if they want to understand more about GIST. This shows what the KIT protein actually looks like, and you can see it's anchored in the membrane of the cell, and what happens is that signals from the extracellular environment bind to that extracellular portion of the KIT protein. In normal circumstances, this causes the protein to bind to another copy of itself, which leads to activation of enzyme within the cell that causes phosphorus molecules to be transferred to other molecules in the cell, which eventually changes the transcriptional profile, the RNA that the cell is making, and that induces the cell to divide and to form a cancer. These mutations can happen at various places in the cell itself, in the protein itself, either outside of the membrane or inside of the membrane, but each of the mutations in the different parts of KIT basically do the same thing by activating this what we call a tyrosine kinase inhibitor, a receptor tyrosine kinase. Rarely in tumors that don't have KIT mutations, you can see mutations in PDGFRA, which acts similar to KIT in the cells. There are also just tumors that are associated with changes in the SDH family of proteins, in the RAS signaling pathway, or in NTRK or FGFR signaling pathways. This second diagram just kind of highlights how the KIT or PDGFR proteins, you can see here 2 copies of the receptor binding to themselves. The phosphorus molecules that they use go downstream to activate classic oncogenic pathways like AKT and MEK pathways, which then affect what RNA is being transcribed in the nucleus, and then that in turn can affect the cancer formation. Once it was better understood that KIT was driving the formation of GIST, that allowed for the development of inhibitors of this molecule. And we know the most common inhibitor now used in the treatment of metastatic GIST is imatinib. So imatinib works by basically blocking the activation of this receptor tyrosine kinase. And I'll go into that in a little more detail when we talk about imatinib resistance. So these are some of the initial trials. This is one of the initial trials that looked at the use of imatinib in GIST tumors. This was a randomized trial for patients with unresectable or metastatic GIST. They were given either 400 or 600 milligrams of imatinib daily. Patients enrolled in the trial averaged an age of, had a median age of 54. They had tumors that had started in various parts of the GI tract and had metastasized to various places within the abdomen, the liver, the peritoneum, the retroperitoneum. Some of these patients had prior surgery, others chemotherapy and radiation. And you can see, if you look at this Kaplan-Meier curve, whereas in the outcomes that we looked at after surgical resection of recurrent disease, where patients recurred and died very quickly after their after their surgery for recurrence. And with treatment of imatinib, after a year on the drug, only 30% of patients had disease that was even growing. So 70% of patients had disease that had stabilized on the drug, let alone, and even more patients were still alive. So 90% of patients treated with imatinib were still alive after initiation of the treatment. So a much more effective intervention than surgery ever had been for recurrent or metastatic GIST. This is just an example of one of the patients who was treated on that trial. These are PET scans. So PET scans are performed by giving an IV marker of sugar uptake. And so where tumor cells are dividing and growing, they're using sugar as a form of energy. And you can see here a large mass in the pelvis of dividing active cells. This is the CAT scan that you can see of the patient. This is the pelvis with these large tumors that have grown and developed in the context of recurrent GIST. After just 1 month on treatment, you can see that these tumor cells are no longer picking up sugar, no longer growing and dividing. And on the CAT scan, the tumor deposits have gotten much smaller. And in this patient, 16 months later, you can still see no active disease on either PET scan and very small lesions, residual lesions on the CAT scan. These are the biopsy specimens from some examples of patients. So you can see here before treatment, quite a new, very packed cells. You can see all of the nuclei right next to one another. You can see these smaller areas, smaller nuclei, which are cells that are actually dividing. After treatment with GIST, you see with imatinib, you see many fewer cells and just scar tissue in the background. That's this kind of pink colored component of this on the see that you see on the slide. That's basically just scar tissue fibrosis. Here again, fibrosis, many fewer cells, and these areas that are a little bit redder, those are red blood cells, small areas of hemorrhage within the cells as they responded. The drug was shown to be very well tolerated. Grade 3 or 4 adverse events or events and side effects that we think are relatively significant. Overall, only about 20% of patients had a significant side effect. These were, in some cases, hemorrhage, so bleeding from the tumors into the GI tract is something we see as patients with advanced disease get started on the drug. Neutropenia, low white blood cell counts, fatigue, and edema. So this is the swelling that you can often see around the eyes or in the lower extremities when you start on Gleevec. But overall, relatively well tolerated, 80% of patients without a major side effect. As a patient, when we diagnose with a patient with metastatic or recurrent disease, the important thing that we know now is that we would almost always want to get a biopsy and sequence the mutations, because as part of these initial trials of imatinib, we were able to show that there was a significant association between response to imatinib and where in the KIT gene or the PDGFRA gene the mutation actually occurred. So just in these early studies, they were able to highlight differences, particularly in the most common mutations, exon 11 in KIT and exon 9. So you can see the exon 11 mutation was associated with a much higher response rate. 83.5% of patients had a decrease in the size of their tumors versus the exon 9 mutation, where only 47.48% of patients had a decrease in the size of the tumors. More of the exon 9 patients you can see here had disease that progressed despite initiation on the drug versus patients who had an exon 11 mutation. So even in the very early studies of imatinib, it was clear that where the mutation was going to be predictive of how patients responded to this drug. And so while most patients do very well on it, it's important for us to get a sense of that right up front by sequencing the tumors. Further studies showed that some of this resistance, particularly in the exon 9 mutation, may be overcome by giving higher doses of imatinib. So you can see here these Kaplan-Meier curves. This is in one of the trials that compared 400 versus 800 milligrams of imatinib in patients with metastatic or recurrent disease. And you can see there was very little difference overall in progression-free survival, so how quickly the tumors began to grow. But in patients who had exon 9 mutations, you can see that those patients who were on 400 milligrams of imatinib tended to have tumors that grew more quickly than those who were on 800 milligrams of imatinib. So we know now that if we see a patient who has an exon 9 mutation, we're going to try and get their imatinib dose if they can tolerate it up from 400 closer to 800. Or particularly if we see them progressing through 400, we're going to try and raise their imatinib dose to 800 so that we can get a better response and better stabilization of the disease. That's compared to here, you can see the exon 11 patients where there was very little difference again in outcomes, whether a patient had 400 or 800 milligrams of imatinib as their daily dose. As there's been continued addition to this data, we can say a lot more about the rarer subtypes of GIST, the rarer mutations. So this just highlights again the differences in response to imatinib in patients who have mutations at different places in KIT. So exon 11 is sensitive to imatinib. Exon 9 tumors tend to happen in the small bowel, and these are less sensitive to imatinib. So this is what we just talked about. We tend to use a higher dose of the drug. Exon 17 and 13 mutations may be less sensitive than those even of exon 9 or 11. PDGFRA mutations tend to be sensitive unless you have a mutation in exon 18, particularly the D842V mutation, which is resistant to imatinib. And then wild type KIT and PDGFR mutations. So these are the patients who don't have a mutation in KIT, don't have a mutation in PDGFR, but have an alteration in the SDH pathway, or these rarer events like NF1 mutations, BRAF mutations, NTRK translocations. These tumors tend to be resistant to imatinib. So the more data we get on the more varied and rare GIST drivers, the more information we have as far as which tumors are going to respond initially to imatinib and which are going to have primary resistance. So primary resistance is a clinical problem, as is secondary resistance. So we know that some tumors don't respond to imatinib off the bat, and then others over time will develop resistance to imatinib too. This you can see is the progression-free survival of patients on one of the initial studies treated with imatinib. These are the exon 11 patients, and these are the patients who had exon 9 mutations in KIT or wild type KIT. And you can see that after about 2 years, while initially the tumors tend to be stable in most patients, and over the first year you have 80 to 90% stability in disease, after an average of about 2 to 2.5 years, we start to see patients progress more commonly. So the median progression-free survival on imatinib for patients with sensitive disease we think of as being in the range of 2 to 2.5 years. And this is an example of a patient who had this problem, a 53-year-old man who had initially presented with a primary small bowel GIST. He underwent exploration. They thought it was only one site, but they found multifocal disease throughout the peritoneum. He was found to have a small deletion in c-KIT exon 11 and was initiated in a course of imatinib. So you can see here his scans in 2013. He had this large tumor in the right lower quadrant. After a year of treatment on imatinib, you can see the tumor's gotten much smaller, and it's not really very avid on the PET scan. So this isn't very bright. There's not a lot of sugar that's being taken up, not a lot of cells that are going to be dividing. But here you can see as we followed him over time, that tumor became much brighter and it started to grow on the CAT scan. So he had this solitary site of resistant disease that was developing near where his primary tumor was. So the question for us often comes up, patient's been stable on imatinib for a long time now, there's a solitary site of disease. What are your options for treatment? So there have been multiple different medical options developed, and a lot of these are based on a better understanding of how imatinib works in GIST and how the mutations secondary mutations can affect imatinib sensitivity. So I just wanted to kind of briefly go over the structure of KIT and how imatinib works and why secondary mutations can affect imatinib sensitivity. So this is another schematic of the KIT mutation. The membrane of the cell comes right across the middle of the protein here. And what happens is that there are several different important domains within the molecule which make it active, which cause it to signal downstream to pathways that cause cancer formation. The most important one, the one that everything filters through, is the A loop, the activation loop. So when the activation loop is on, it's transferring signals downstream. What imatinib does is it binds to a portion of the molecule that causes another component of the protein, the autoinhibitory loop, to keep the activation loop, to inhibit and to keep the activation loop from signaling. So most of the exon 11 mutations are in the autoinhibitory loop. And so that means that this innate inhibition of the activating loop is not happening. And imatinib, when it binds, forces the autoinhibitory loop back into a position where it prevents the activating loop from sending downstream signals. So Dr. Antonescu and Dr. Di Matteo here at Memorial did studies on patients who had tumors that became resistant to imatinib. And what they found was they studied 31 patients treated with imatinib who then underwent surgery. 18 of these patients had resistant disease, and they were able to find secondary mutations in the gene outside of the initial exon 11 mutations that were associated with acquired secondary resistance to the drug. Most of those mutations were in exon 13 or 14 or 17. So the ones in exon 13 and 14, those are around amino acids 650 and 670. You can see those are in this portion of the protein where the imatinib is binding. So by mutating there, you change the structure of that part of the protein and imatinib can't bind. Exon 17, they showed that's down in the nearer to the activation loop, and that actually prevents it from interacting with the autoinhibitory loop at all and just makes it constantly signaling downstream without the ability to be inhibited by imatinib forcing the autoinhibitory loop to stop it. So they were able to show ways in which the secondary mutations specifically affected how imatinib could either bind to the receptor or how the protein got around the way in which imatinib works to inhibit downstream signaling. And so after that point, people started to look at other inhibitors of KIT and PDGFR, which maybe worked by different mechanisms and bound to different parts of the KIT protein. And the next one they studied was sunitinib, which is another type of inhibitor of KIT, PDGFR, and VEGFR2. These act more on the outside of the protein, keeping it from binding to itself, keeping the ATP that gives energy to the receptor from binding. And when they looked at this protein in studies, what they were able to see was that by targeting the KIT and PDGFR receptors in a different way, you could again get responses in patients who had initially been resistant to imatinib. So here, this study, they looked at 312 patients with just after imatinib failure, 2 patients, and they randomized 2-to-1 to get sunitinib or a placebo, so a sugar pill. Again, the patients were pretty similar in each arm, in age, in histology, in how big their tumors were, in how long they'd been on imatinib, on how long they'd been on imatinib before their tumors progressed, and how they'd responded to imatinib. And you can see here, patients who were on the sunitinib drug as compared to the placebo did much better. So progression-free survival overall on sunitinib was close to 24 weeks, so 6 months, whereas patients on the placebo, the tumors were growing after a month to a month and a half. So this is why, based on trials like this, sunitinib is generally used as second-line therapy in patients who develop imatinib resistance during treatment for metastatic or recurrent GIST. We also know that sunitinib response is dependent on where your mutation is. So here you can see patients who had exon 9 mutations, patients who had wild type, and patients who had exon 11 mutations in their primary tumor. Those patients who had exon 9 actually did better with sunitinib than those with exon 11 mutations in their primary tumor. And patients whose secondary resistance was related to an exon 13 or 14 mutation, the imatinib binding site, versus exon 17 to 18, the activating site, those with 13 to 14 mutations did better on sunitinib than those with exon 17 to 18. So even in the context of secondary resistance and second-line therapy, mutation status can give you a sense of what drug, or whether or not to expect a response to second-line therapy with sunitinib. Because sunitinib, patients develop resistance to sunitinib after an even shorter period of time than they do to imatinib. There's also been extensive studies now on third and fourth line drugs to try and control the disease for even longer. So the most commonly used is regorafenib, and this study was published in 2013. Regorafenib actually inhibits not only KIT and PDGFR alpha, but also a number of other proteins on the cell surface, receptor tyrosine kinases like VEGFR2, FGFR2. It inhibits the RAF and BRAF components of the RAS pathway. And so patients on regorafenib, again, even if they have failed on imatinib and sunitinib, can get additional benefit from regorafenib. So you can see here 6 months after treatment is about the median progression-free survival on this drug after having progressed through sunitinib and imatinib. Mutation isn't as important in predicting response to regorafenib. The one thing that's important to recognize, though, that's different is that because regorafenib hits a much broader number of receptor tyrosine kinases and enzymes in the cell, the side effect profile can be a little bit more extensive and harder for patients to tolerate. So you can, if you remember, in the initial trials of imatinib, grade 3 toxicities were in the range of 20%. You can see here with regorafenib, those numbers approach 60%. There are often things like high blood pressure, hand-foot reactions. Patients can commonly get diarrhea with this drug. So the problem with just proceeding with continued medical therapy and trying different drugs is that often our third and fourth line therapies now are associated with much greater toxicity than the toxicities we saw with imatinib. So this is where surgery a lot of times comes back into play. So if you remember, surgery alone, we said, was of limited benefit in patients who had metastatic disease before imatinib. So patients progressed quite quickly after they had their recurrences. But this is a study recently done again at MSK on about 1,000 patients who were treated surgically for GIST at our institution. And in this study, they looked not only on patients who had primary disease treated with surgery, but in patients who had primary and metastatic disease or metastatic disease alone, and compared outcomes before the introduction of imatinib and after the introduction of imatinib. So that you can see here, patients who were treated for surgery for metastatic disease after the incorporation of imatinib in their overall treatment plans did much better than those patients treated with surgery prior to the introduction of imatinib. So this data suggests that surgery may, in conjunction with the TKIs, the drugs that we use now for treatment of GIST, may be of more benefit than it was historically. So, for example, in this patient that I showed you earlier, this 53-year-old man who presented with primary small bowel GIST, who had a solitary site of recurrence, he was referred to me with the question, should we just take this site of recurrence out? And there are some theoretical benefits to that. If we take that solitary site of resistant disease out, even though we're probably not taking out all of the sites of GIST that are in the abdomen, if those sites are being controlled on imatinib, then maybe if we take out this tumor, we can make imatinib work longer, if that makes sense. So we're taking out the solitary site of disease and using surgery to get rid of it, and then imatinib is taking care of the rest of the disease. And this may be a good thing, because then that means the patient can stay on imatinib, which has a relatively low side effect profile, as opposed to progressing and going on to sunitinib or regorafenib, which can have iteratively more side effects to them. So we did take this tumor out last year, and he hasn't shown any additional signs of regrowth while continuing on imatinib. So the theoretical reasons to consider cytoreductive therapy in the context of resistant disease: if we remove the resistant site, that allows for continued therapy on a lower toxicity tyrosine kinase inhibitors. It's not clear that it would necessarily improve survival, but it does, in some way suggest that we can help our patients have a better, longer quality of life. The other thing that's been brought up is that if we take, and the other place that surgery, so that's one place where we think surgery benefits patients who have solitary sites of secondary resistance. There's also a question and a debate that's been brought up. Well, what if we took that tumor out? We saw it was still there on his scans. What if we took it out before it became resistant and take out all the other disease that we can see? Will that potentially reduce the number of cells that develop resistance? So if you assume you have 1,000 cells in place, or many more if you have a tumor there, but if you have that many cells, each one has a designated chance of developing resistance. If you took those cells out before they could develop resistance, if you took out 90% of them, now you've only got 10 or 20 or 100 cells left behind that can develop resistance. So does that help a patient by trying to minimize overall the number of cells that can potentially develop resistance? And some people would argue that you should go in and take out all the disease before the tumor becomes resistant. And that's kind of based on studies like this. So these are studies out of, this was a study led by Dana-Farber Cancer Institute that looked at their patients as well as some that had been operated on in our institution. And they looked at whether taking out all of the residual disease at different time points in a patient's course, how that was associated with outcome. So these graphs, because they're not in color, are a little hard to read, but you can see if you waited to try and take everything out while there were lots of tumors that were growing through imatinib, patients tended to recur and die from their disease relatively quickly, so after 2 or 3 years. If you took it out after only one site of disease, then you can see that the outcome was much better. So patients were still alive with their disease 4 to 5 years after their surgical resection. And this was even better if you took all of the disease out while the tumor was still responding to imatinib. So there has historically been an association between taking out all of the disease while it's still resistant, as opposed to when it becomes resistant, and better outcomes. The argument against particularly taking it out when it's still responsive versus when you have one-sided disease that's progressing is this difference only because patients here are a little bit further along in their disease to start with than patients who are still responding to the drug. And so if you look at the outcomes based on not just the time from surgery, which these graphs do, but the time from when you start imatinib, at least the outcomes for patients with unifocal progression versus those who have stable disease are pretty similar. So we, in general, would wait to do surgery until patients have unifocal progression, but there's still a little debate in the field overall as to whether that's the case. And people have tried to do studies that prospectively look at this, but it's very hard to accrue patients to a study when you're going to tell them that somebody else is going to decide whether or not they're going to have a surgery versus just stay on medicine, as opposed to them being able to make their decision themselves. And that's completely understandable. So those types of studies would be very difficult to perform. So we rely really on data like this. A couple other places where we think about surgery. One place where I've done surgery for metastatic and multifocal GIST recently is in a patient who had NF1 disease. So patients with neurofibromatosis have a genetic condition which puts them at risk for developing GIST. These tumors, though, tend to be very indolent, that meaning they grow slowly compared to other types of GIST, despite the fact that they can develop in multiple places in the small bowel in the same patient. You can see that these are just stains for the interstitial cells of Cajal, and you can see how in patients with NF, there should only be one or two of these cells periodically noted in the intestine. And here you can see that they are overgrown and what we call hyperplastic throughout the intestine. And so this is this oncogenic, the cancer-causing signals in these cells are, the initial ones are kind of always on in these tumors so that they get this hyperplasia. But what can happen is that some of these tumors, while they grow slowly, can cause symptoms. So in this patient, she had what was thought to be a fibroid a few years prior, had undergone surgery, the tumor ruptured, and she had a recurrence. You can see her here on the PET scan in the right lower quadrant. It was causing some intermittent obstructions. So we went in and we took that out. And at the same time, we took out several other small sites of disease, which had slowly started to grow back. So this one's a little more difficult to see, but in her pelvis. And she's now 4 years out without recurrence. So she may still have small sites of disease, but they grow slowly. And since they're relatively resistant to the current drugs we use for GIST, we will, in the context of symptoms, try and go ahead and take these out along with associated disease where it's safe. So just to sort of summarize what we've talked about so far, the basic algorithm for the treatment of metastatic GIST with c-KIT mutations and most PDGFR alpha mutations is 400 milligrams of imatinib with sequencing of the tumor. You may consider a higher dose for patients with exon 9 mutations. And then as disease becomes resistant, you tend to transition to sunitinib and then regorafenib and integrate cytoreductive surgery in the context of a disease that's either responding or progressing unifocally to remove resistant disease and allow patients to stay on the lower toxicity drugs for longer periods of time. So just a little bit now about where the field's going and how the most recent studies are trying to look how to improve care for patients in fourth-line settings and with tumors that are resistant to all standard therapies. So for example, the PDGFR D842V mutation. So if we look back, we talked a little bit about the structure of imatinib. The most recent trials are actually looking at drugs that may inhibit the activation loop themselves. So not trying to indirectly affect signaling, but to get at it directly. And so avapritinib works in a little bit indirectly by doing that. It binds to the site on the protein that gives energy to the activating site, to the ATP binding site. And the Navigator trial examined this drug in patients with GIST, and particularly in patients with the D842V mutations, because these mutations are actually affecting this region down here by the activating loop. And you can see this is a waterfall plot. What it does is it shows the best response in each patient, whether the tumor grew, in which case the patient's, the bar representing a patient's tumor is in the positive territory, or whether it shrank. And you can see here in the patients with the D842V mutations, avapritinib induced a response in almost all participants in the clinical trial. So this was a really phenomenal result on par with what we see in the initial trials of imatinib in sensitive patients. And this was a secondary study done in retrospect where Dr. Van Maren and her group looked at how patients with this particular resistant mutation responded to avapritinib as compared to the other tyrosine kinase inhibitors we talked about, like imatinib and sunitinib. And you can see how they're doing much better in terms of progression-free survival and overall survival. You may ask why we don't put all patients on this drug. It does seem like it's causing some cognitive side effects, which can be quite concerning and difficult for some patients. So we do still keep it for when we have limited other options for a patient based on their mutation status and their prior response to drugs. But it is becoming a good option, and you can see patients have really a good sustained response to it, with about half of patients still remaining without growth of their disease after 2 years on study. So additional therapies on the horizon. Ripretinib is being integrated into the primary treatment algorithms for GIST. Again, this binds to the KIT protein in a different way and has shown in phase 3 randomized placebo-controlled trials to be active even against difficult to treat primary and secondary mutations. There are ongoing trials trying to see how best with these new drugs to sequence things in terms of whether ripretinib should be done before or after regorafenib and or sunitinib, and the same thing with avapritinib. We know as we study more and sequence more tumors, we can identify more rare drivers of GIST, and some of these, like NTRK translocations, can be targeted with specific drugs, NTRK by larotrectinib, dabrafenib for BRAF mutations. And combination therapies are now being looked at as we understand GIST biology a little better. This is a study by this is based on some work that Dr. Ping Chi has done. And she's done really some elegant work in the lab that shows that the KIT protein actually interacts with another protein that's expressed in the interstitial cells of Cajal, ETV1. And ETV1 is modulated by KIT, but specifically by MEK, another signaling protein in the tumors. And so she's done studies where she looks at what happens in GIST cells where you inhibit the KIT mutation with imatinib, and you also inhibit MEK directly. And you can see in these charts where you look at combinations of patients treated with imatinib, and here with increasing combinations of a MEK inhibitor. As you combine the two drugs together, the cells stop growing much better than when you treat with imatinib alone. And so this has been done, this combination has now been looked at in clinical trials, and she can see response rates with the combination that are higher than you would typically see in patients treated with imatinib alone. So there's some new combinations that may be quite exciting in the treatment of GIST. This is important too because it might help us to address some of the more treatment strategies for some of the more resistant tumors. So MEK is also a central pathway involved in NF1 induced GIST formation. And so here you can see a patient who had NF1 associated GIST where they got treated on the MEK trial, including a MEK inhibitor. And we could see that the disease responded in that case. The tumor here you can see pre-treatment and post-treatment getting much smaller with these alternative targeted therapies. So a tumor that was traditionally resistant to drugs like imatinib, more sensitive by targeting the pathway in different ways. So just in conclusion, development of tyrosine kinase inhibitors has really revolutionized the care of patients with GIST. Tumor sequencing, as I've shown you some examples, is increasingly used to determine appropriate therapy. And while surgery may be curative in localized GIST, it's used as an adjunct to tyrosine kinase inhibitors in most cases of metastatic disease, trying to allow us to keep the drugs to working longer for patients. And ongoing improvements in our understanding clearly allowing us to develop new therapeutics and drug combinations to better treat patients with metastatic disease. So again, thank you very much for having me today, and hopefully we have plenty of time for questions.
Thank you, Dr. Crago. That was an excellent presentation, and it was nice to see you address some of these common questions that patients ask regarding surgery and metastatic disease. It's nice that you addressed that topic. So we have a few questions that came in. Others can feel free to write in the Q&A. The first question is there much evidence, is there much evidence of just metastasizing to the endometrium of the uterus?
It's not necessarily one of the places where we would think of it as metastasizing primarily. The liver is by far the most common place that it's going to metastasize if it doesn't recur locally or around the peritoneum. But we see strange things all the time and new presentations in different patients. So I always tell my sarcoma patients it's hard to tell them not to worry about something rare happening because they've already had something phenomenally rare happen to them. So it's always possible, but not common.
Good point. This patient had surgery in 2020 with a total gastrectomy and liver resection, removal of the spleen, gallbladder, and reconstruction of the diaphragm with all clear margins, exon 11 mutation. They've been on 400 milligrams of imatinib. Initial tumor size was large, 19 centimeters. They would just like to know, would they be on imatinib for life as advised by the oncologist?
The use of imatinib in the adjuvant setting, if you had a solitary tumor and only one site of disease, there are clinical trials that show that in the context of certain tumors with certain characteristics, it can be a benefit in terms of keeping the tumor from coming back. And there are some trials that show that may translate into small changes long-term in over survival. So for small tumors where the risk may be moderate, some people can take a trial off imatinib, but that really depends on a lot of different characteristics and what your overall risk is from the tumor. A 19 centimeter tumor may have been growing quite fast, and so that might be more worrisome because what we know is that when you stop imatinib in the adjuvant setting, a lot of patients will start to recur. And so if your tumor was high enough risk to be of significant concern for your oncologist, while in some patients we may be able to stop it after 3 or 5 years. In others, we feel that it would be of benefit to keep it on long term. So that's a very specific question based on a lot of characteristics of your tumor. But it's not unreasonable in certain scenarios to be on it lifetime in the adjuvant setting. In other cases, some people can come off of it after a designated period of time.
Okay, thank you. Another person wanted to know about any results from a newer trial. It's actually run by Daiichi Sankyo, and it targets the GPR20 protein. What percentage of GIST express this protein?
I don't really know that answer. That's not one of the clinical trials that I know really well, or one of the more common
Yeah,
drugs.
it's a relatively new one, but maybe the Life Ref group can look into it for that person. We can get back to them. For those with metastatic GIST from the beginning, what is the recommended schedule for CT scans following surgery? It seems that the time between scans increases, when perhaps maybe it should be the reverse.
I think it's a little bit dependent on each person's overall risk, how extensive their disease was. For most people, if they have metastatic disease when they first start on imatinib, you're going to probably get your scans after 8 weeks, maybe 12 at the most, to see how you're responding. And that's because we want to get an initial sense of make sure that the drug is working in you. The mutations can give us a good idea, but there's always a patient who should respond and doesn't, or shouldn't respond and does. So you're also going to see your medical oncologist much more frequently to start with to make sure you're not having side effects related to the drugs. Then over time, as we see that your tumor is responding, if your disease burden, meaning how much tumor is left, is quite low, you might not come in for scans quite as often, because the end of the risk, once we know that your tumors are doing so well, of it starting to grow between scans may be not quite as high. So we start to spread the scans out a little bit more, because it would be pretty hard to do scans every 8 weeks indefinitely. So
Right.
most people, once we know you're stable on the drug, would be on getting scans maybe every 4 months, and maybe even eventually every 6 months if it's been several years.
Yep. That seems to be what we see as well among our group. This person wants to know, do you know of any progress in research or treatment of quadruple wild type GIST, SDH competent, no BRAF, NF, and TRK mutations?
Yeah, I mean, I think for these patients, we're a little less, we don't quite have the data to drive an answer to that, right? So when we know you have a mutation, we have data to kind of guide us and um, give more, we have more data to tell us what your chances of responding to any one given drug are. And when you have none of those mutations, it's a little bit hard to know exactly what caused your GIST. So most people would still get a broad screening panel to see if there's any new mutation that we haven't seen before that we could potentially target with a drug that isn't usually used with GIST, or be tried on one of the standard tyrosine kinase inhibitors, expecting that whatever the mutation was may still work indirectly through c-KIT. So in those cases, there's a little more trial and error to how we treat a patient, um, but hopefully as we continue to sequence, we'll find more of the mutations that are responsible for the tumors that we still can't uh, associate with a known driver.
Right. Okay, great. Thank you. I was recently put on Sutent because my tumors became resistant to imatinib. One was removed along with my ovaries. A test was done on it, and I was told I have no mutations. Is this unusual?
Um, it's not completely unusual, right? If we look even back at the original tests that in the original study that Dr. Antonescu and Dr. Di Matteo did, only about half of the tumors that were resistant did they find a secondary mutation in. So I think the more we sequence, the more mutations we find. It's hard, unless we start seeing those in multiple patients, to know that they really are the ones that are causing the problem. And it may be that it's in a gene that we just don't understand affects imatinib or downstream from it in a way that we don't understand yet. So it can happen that there's not a mutation that we find when we look for a reason for secondary resistance. And it just means we haven't sequenced enough tumors to try and understand what's happened to you.
Good point. Good point. Okay, is there any indications that increasing imatinib dosing may cause resistance to imatinib sooner? I've increased my dose from 400 to 500 milligrams after following my imatinib levels through therapeutic drug monitoring.
Yeah, I don't know that we have that data, or whether the fact, we don't, I don't think that we have that data, and we don't even really have good data to know whether or not monitoring levels changes it. It might be that in some patients, having the higher or dose is just a function of how quickly you individually clear the drug. And so even though your dose is higher, the amount in your bloodstream is the same, and it may not affect resistance. But I don't think we clearly know that would be the case.
Okay. It seems like during the last 20 years since imatinib, the most we've been able to do is add 6 to 12 months in progression-free survival via the new TKIs. Is there something on the horizon that can drastically increase those numbers? That's the $1 million question.
Yeah, I mean, I think that those are what the new studies are trying to look at, right? Avapritinib, the disease, the progression-free survival is pretty long on that study. So will these drugs, ripretinib and avapritinib, be better than sunitinib? I don't think we quite know yet, because they've been studied in such in patients who've had multiple different drugs beforehand. It's also possible that some of the combination drugs combination trials may up front kill more of the tumor when used in combination with imatinib, so that there are fewer cells to develop resistance. So I think all of these things are being studied now, because you're right, that is the $1 million question. How do we keep people from suffering from the disease if they've developed imatinib resistance?
I think at the Life Raft group, we try to say as long as we can keep these patients on imatinib as long as possible, then
Yeah.
it helps in terms of the length of time that they get.
And that's definitely how we try and use surgery. And, that's when you chemo, like arterial embolization of liver tumors and things like that, to try and take care of the resistant tumor so that you can continue on imatinib to keep the rest of the drug stable.
Okay.
The disease stable.
Okay, so more questions came in. Thanks for your patience. So given propensity for imatinib resistance over time, is there an argument to wait after initial unifocal resection until disease returns? It seems it buys you more time and better quality of life.
So in those patients who had resection of unifocal disease, the problem is that tumor was what was growing, but there are probably other cells left behind that are still viable from the other tumors that are just being controlled because of the imatinib itself. So you still have to go back on the imatinib after resection of the unifocal disease progression, because it's what's controlling some of the other cells in the other tumors that were there and that shrank away when you started the drug.
So this person is taking sunitinib, which has helped reduce the size, but I guess they're concerned if the tumor does become resistant, what would be the next step? One example was ripretinib.
Yeah. I think that there's not really, it's not really clear right now how we're going to sequence ripretinib and regorafenib. I think that how ripretinib and avapritinib are going to be integrated into the standard imatinib, sunitinib, regorafenib paradigm is still being worked out. Whether they stay fourth line or whether one of them replaces regorafenib as third line is unclear. So that's being done by trying to compare those drugs kind of directly.
And sort of on the reverse side, I think another patient wanted to know, well, maybe how can you prevent some of that resistance? And they were thinking, well, even maybe up front with the primary treatment, maybe using ripretinib, could it have some more advantages over the other inhibitors?
Yeah,
Quite sure.
I think the thing with ripretinib and avapritinib is a lot of the issues are the same as with regorafenib. They're targeting the tumors in different ways, and their side effect profile is a little bit different, so that it may be the side effects become more difficult to tolerate than those that you get with imatinib. So those things are all being considered as we determine how best to stage all of the now 5 FDA-approved drugs in the treatment of GIST.
I think we're just going to leave room for one more question. And this is about the role of using radiation to shrink and encapsulate the tumor prior to surgery. Could you speak to that?
So GIST is historically considered a radiation-resistant tumor. So we don't tend to use radiation in GIST. The only place where people are starting to study it a little bit more is in the context of liver disease. If you have a site in the liver that's resistant in a place where you can give a really high dose of radiation, would that be a possibility? But historically, GIST is not considered to be a radiosensitive tumor, and so we don't see responses that are good enough to justify giving it before surgery in the same way we do with other sarcomas.
Okay. We threw a lot of questions at you. Thank you so much. Um, we are out of time. I do want to point out that in a couple weeks, we're going to have her colleague from Memorial Sloan, Dr. William Tapp, give a talk on new treatment updates for advanced GIST. So feel free to be tuned in then and ask your questions. But for today, I would like to thank Dr. Crago for her time and her presentation. Clearly, it generated a lot of interest, and we want to thank you for presenting today about this important topic.
Well, thanks
So
again for having me. It was great.
amazing. Okay, everybody have a lovely day. Be well.